Okay. Hello. Good morning, everybody. I'm Stefano Gasparini, and I'm talking from Ancona, Italy. It's a great pleasure and an honor to introduce my friend and our colleague, Mohsen Davoudi, that is coming to Italy from Irvine, California. Mohsen Davoudi has a very, very interesting history. His works in the pulmonary and critical care medicine and interventional pulmonology and thoracic oncology service in Beckman Laser Institute of the University of California, Irvine. And he has a very interesting history because he is a citizen of the world. Is unbelievable because he studied in Swiss, in Lausanne, in Tehran University, and that he worked in several places in the world and in the United States, in Harvard University, in Yale University, in Albert Einstein University in New York, and now he is in the University of California. He started his activity as a pediatric surgeon, and then he moved to pulmonary disease specialty and interested about critical care medicine and interventional pulmonology. In the history of Mohsen, that is a citizen of the world, there are a very, very wonderful point because everywhere in the world there is need for some help and for some skill in pulmonary disease. He is available to come. And at the beginning of the COVID pandemic in Italy, at the end of February, I received a phone call by Mohsen that asked me, I would like to come to Italy to help Italian colleagues, to help Italian pulmonologists, and to help Italian people. At that time in Ancona, there were no many cases of pneumonia. So I said to Mohsen, maybe in north of Italy there is more need for your help. And I called Michela Bezzi in Brescia, and she was very happy to receive the visit of Mohsen. Mohsen arrived in Italy after a very, very difficult trip because at that time some airports were already closed. But he was able to arrive in Brescia, and he worked in Brescia for March and April into the 2 months where most of patients with COVID were arrived at the hospital. So he did a great experience, and he provided a great help to the colleagues in Brescia, and he worked a lot for our patients. So it's my pleasure to say him thank you very much on behalf of all the Italian pulmonologists and on behalf of the Italian people for his voluntary help that he did during this terrible month. Now that the situation is going to be normal, he arrived in Ancona just to share some experience in interventional pulmonology, and now he is here in our hospital. So I asked him to share his experience with all the Italian pulmonologists and all the pulmonologists that are connected about this lesson that COVID-19 gave us, learning from our experiences and mistakes. So it's a great pleasure for me to introduce Mohsen Davoudi that will give us his lecture about this topic. Thank you very much to be connected and enjoy this webinar. Please, Mohsen.
Buongiorno. I say hello and greetings to my wonderful Italian friends and colleagues. It is an immense pleasure to be given the privilege to speak to your esteemed societies. What Stefano said about me, Professor Gasparini, was very kind and somewhat exaggerated. I am not such a person as he said, but I do have an affection for Stefano and my other wonderful friends in Italy, and I've been really, really honored and pleasured to be with you these past months. Uh, the topic of our conversation, as Dr. Gasparini said, is learning from our experiences and mistakes. Uh, uh, as you know, after difficult operations, surgeries, military operations, surveillance operations, we debrief. We go over what we have done and we try to find fault with what we did less than perfectly, and we try to fix it. As we all know, during the COVID pandemic, we started almost knowing nothing about this disease and this bug, and we inadvertently didn't make the perfect decisions at all the right times. And so I'm hoping this disease will not come back the way they say. I'm hoping another disease like it will not come back the way they say. But if it does, let us learn from these experiences and make sure we don't make the same mistakes. Uh, I don't think we got all of it right, and I would be surprised if someone said we did get all of it right. So the only way to make sure we don't make the same mistakes is be honest about ours. And I think that as people who have dealt with this disease over the past 3, 4 months, it is upon us all over the world to come together and make honest lists of what we have done and what of it was right and what of it was not right, and basically troubleshoot for the potential next time. We should never be ashamed of accepting that we made mistakes and did anything wrong, because to say that we did something wrong is only to accept that we are wiser in that respect today. And who doesn't want to be wiser today than yesterday? And it's fine to congratulate ourselves and pat ourselves on the back for what we did and what was done everywhere. In Italy, I saw with my own eyes, and I was shocked and impressed and in awe of what you did. But more important than giving ourselves congratulations is looking at what we did that was less than perfect, and heed the lessons and never do it again. Uh, the, This very small conversation in 45 minutes is a distilled version of a maybe 2 to 3 day symposium that is being prepared, and we have broken down the topics, the categories of the uh, different steps of dealing with COVID as a healthcare institution and as a society, and they come under several categories. Obviously, I can't summarize a 3 day symposium in 45 minutes, so much of what I say will be like bullet points, and each of these hopefully possibly could be topics for further, much more further discussion. So if I talk very fast and if what I say a lot of times seems like I'm just giving you lists, I think it's the nature of this beast, because the amount of matters and issues that we need to talk about and speak about are much more than one could imagine. This is the enemy, this is the disease. These next few images I have taken from the NIH and CDC websites for copyright purposes. And I'm not an electron micrographer, so what I'm telling you is based on what I read in the legends. This is the COVID virus among the dendrites, apparently, of dendritic T cells. This is the COVID bug inside the cells, and these up here in the corner apparently are pieces of the protein capsule being constructed by this cell's protein making apparatus, and these are assembled viruses waiting to break out. And these are the viruses after they break out of the membrane and they have ruptured the cell and they are going to their next target. And this again apparently is a dendritic T cell covered with tens of thousands of virion. So back to this list of ours, we have diagnosis, we have triage, we have protection, both of our patients and ourselves, we have treatment, mostly talking about pharmacotherapy here, issues of oxygenation and ventilation, and managing the most important complications, especially the issue of coagulation and anticoagulation. Diagnosis, we treated this disease a little monolithically and with an expectation to see a homogeneous presentation. Some of the original approaches were based on the rules in and rules out, were based on expecting most patients to present with similar manifestations and symptoms. This very nice schematic from Nature that came out in early April actually summarizes how various and different our patients present, and we should have a very high index of suspicion, especially when the disease prevalence is on the rise. And although we shouldn't be in a COVID panic and call everything we see COVID, but at the same time, we shouldn't be inadvertently ruling people out just because they don't have the exact same symptom complex as we expect. Another set of errors that have been made and are continuing to be made, unfortunately, in many places are obtaining specimens. Information technology people have a principle called GIGO, G-I-G-O, garbage in, garbage out. If you give bad input to any system, the output is going to be bad. So if you collect a bad sample, you can't expect the best lab test to respond positive. So the specifications that the several different varieties of swabs have had, when performed by the companies and when tested by healthcare institutions, are almost invariably higher than when done in society. And sometimes this margin is a very, very thick margin. Thus, we know that some places, at least, we're not doing this right. So very, very good education about how to obtain the specimen, how to transport it, and how to test it at least allows us to have as high as possible of accuracy for our tests and as low as possible of false positives and especially false negatives. These are just some images from that New England paper, and I have seen it done right and I've seen it done wrong, and it's really not rocket science, as you know better than I. So we just should make sure that if this ever happens again, this is a very important part of our correct data input to the system. There have been a variety of different ways to diagnose SARS other than clinical and imaging, which we will come to in a second. This was a very nice summary paper in JAMA. And as you can see, the timing of each sample highly correlates to when we would expect it to be positive and when we wouldn't expect it to be positive. And to be aware of this as clinicians and try to superimpose this on the patient's story, on the patient's possible likely point of infection, the person that they think, or the persons that they think at the points in time when we think they got infected, and trying to superimpose it on a graph like this is important in not asking the wrong question, not looking for the wrong test, and not taking wrong lessons or wrong conclusions from the tests that we administer. Interpreting imaging has been a very interesting and important part of diagnosing COVID. My wonderful and amazing colleagues in Brescia, Drs. Borghesi and Maroldi, came up with this schema very early on, and it has been helpful worldwide. And I think as Italians, you should be proud of these folks. And as you know, I'm not going to go into it in detail, but it divides the lung fields into 6 sections, and it gives 0, 1, 2, or 3 scores to each section, and then it adds it up like 1, 2, 2 on one side here, 1, 2, 3 on one side. So you see the data matrix up here, and you see the sum here. And so obviously 0, 0 on all 6 would give a score of 0. and 3 on all of them would give a score of 18. So the score ranges between 0 and 18, and to have it in this organized way, it makes us have a unified language of speaking with each other, and it also gives us a measure of following our patients' progress of disease or progress of improvement. These are just some examples. To diagnose how much their disease has spread in the lung and how severely we expect it to appear clinically has been proven to correlate with the amount of well-aerated lung that is preserved. And this was, again, another wonderful study done by Italian colleagues in Parma, I believe, if I'm not mistaken. I'm sorry if I forget this. And it correlates the amount of aerated space on CT, and it gives you a very nice way to calculate this, and it correlates it to outcome, both having severe disease and also ICU admission and death. This is the schema that it uses. There is a software down here, and although it's proprietary, I believe it's free. So it's down here. I've tried it, and these are the schemas that come out of it. These are the images that come out of it, and you can see it superimposes the disease part on the aeration, and then it gives the color code. If you would like to, just take a random patient's CT and try it out, and it's fun, and it's very effective, and it's relatively accurate, and it has a good inter-rater reliability. If 3 people do it, they come up with similar numbers. This is a paper that actually came out early this morning, late last night, and it's in the American Journal of Respiratory Care Medicine, the Blue Journal, and we know that COVID has different severities. And when we're diagnosing COVID, if we look at the right markers and hallmarks to score and grade the disease severity, it makes us invariably make better decisions for the patient. Because if we are calling someone a very severe disease, while most of their clinical markers, or all of them, are pointing to relatively mild disease, we may make too much of an aggressive decision for a patient. For example, just intubate a patient for oxygen saturation of 85% on room air, while they probably will have a mild course and will not need this level of invasive treatment. On the other hand, if we underscore a patient and not accept how sick a patient may be, we may keep a patient on non-invasive ventilation for 4 days, expecting them to get better, and develop all sorts of complications, while their score initially pointed to the fact that they would be extremely sick. One of the parts of this the paper, the way they score the severity, is based on chest imaging, and this is actually a very nice thing that shows a nice set of images that shows the same patient going through 6 different stages of the CT, from very minimal linear infiltrates to ground glass to consolidation to patchy resolving consolidation to consolidation that's gone back almost to ground glass with tiny reticular nodular infiltrates here, and then basically these tiny interceptal linear markings that are the hallmark of scarring off and resolving disease. I'm going to switch gears here to the topic of protection now. One of the things I think that we all admit we weren't very good at, and sadly, very, very sadly, because we all know friends and colleagues who we have lost, we lost several hundred physicians, probably more than 1,000 or more, nurses and other staff. In Italy, I know there's been something like 200 and something physicians, very sadly lost, and more nurses. If we had known what we know about protecting ourselves and the things we need to do to get it right with PPE and putting it on and putting it off and air control, etc., we would not have made this grave mistake, and these wonderful people would be with us today. So being aware of correct protection and also being aware of when we expect the virus to be transmissible is an important part of what we need to learn from this experience. I will not go through the details of this paper. This is a very good paper that came out in Nature Medicine, and we modeled the expected time of viral shedding on seasonal influenza and the SARS epidemic of 2003. Obviously, and we will get to it in a second, we were wrong, and the viral shedding pattern was much more erratic and more early than those two diseases. So we probably were infected several times more by asymptomatic or pre-symptomatic patients than we were by the sick people. And to be aware of this actually has led to the fact that today we are all walking around with masks and keeping our distances, because if we expected the vast majority of people to be shedding viruses and be contagious, to be the ones who are already sick or are about to be getting sick, or we wouldn't need to be taking the measures we are now. This is, again, I will not go into detail. I'm skipping some slides because, again, of the limitation of time. I apologize for this to all of you. This is a very nice and telling and teaching but sad story of how one healthcare worker who comes into a nursing facility for elderly people brings in the disease and infects probably one or two people in one of the units. There were 4 units in this facility, and because this person, both the person who infects them and then the persons who got infected, the actual old elderly patients in there, were asymptomatic or pre-symptomatic, by the time these people developed symptoms, they had already infected a lot of people in the other units. So being aware of this now makes us very cautious, and being aware of this now tells us that when there is a disease like this lurking on the horizon and we are faced with it like we are today, and we will be for a while, we need to be preemptive and protect people regardless of whether they are symptomatic or not. And as you know, again, so coming to the important point, asymptomatic transmission is the Achilles heel of our current strategies. Because if everyone who was diseased would basically show, we would have a much easier time with this. This is a very, this again came out just this morning. This is on the June 1st copy of the Blue Journal, and it tells a story of a Chinese lady who was only CT'd, although she was asymptomatic, because her husband was found to be SARS positive. And as you can see, she has the disease, and then she tested positive. Later on, she developed a very short period of fever and then never was sick. So this is essentially the typical asymptomatic person. If this girl's husband had not been sick, she would have just written that half day of fever or 1 day of fever as just having a bad day or being tired or having not slept well, and we would have never known. And she would have been out there talking and coughing and sneezing in our faces, perhaps, or just speaking. And as we know, and we'll see in a minute, even normal speaking is a way to spread the disease. And so this is a very nice little example, just one case of how asymptomatic disease could be real, present, anatomically visible, and then with the antigen, with the PCR test, testable. Another study, I will not go into details, in Santa Clara County, California, they tested and sampled and then extrapolated the number of people who had antibody seroprevalence to SARS-CoV-2. And they found out, and this number is staggering, it is indeed jaw-dropping, staggering, that 25 to, their epidemiological model has a range, 25 to 96 times more than the people who are known to have had COVID, who had been sick with COVID, were seropositive for the virus. Their immune system had encountered the virus. So up to 100 times more than the people who we think are positive with COVID could actually be running around with it. So when the disease is around, essentially every person you see is diseased. I know this sounds paranoid, I know this sounds scary, but this is the only way we will protect our elderly and ourselves if this happens again. Again, I will skip this. This is again techniques of using the personal protective equipment. Having them is important, tasting them is important, and then using them properly. The education should be meticulous. And I was very happy and proud to see how, when I came to Italy, Every nurse that I saw corrected my technique in putting on or taking off my PPE. So I learned it from your nurses, and I learned it better than any Johns Hopkins video. So educating the staff and educating the staff that it's okay to educate others who are doing it wrong, because you're actually helping them and protecting them, is wonderful. And I think in this instance, at least by the time I got here, you folks have done an amazing job. To know how to protect ourselves, we have to know how the disease spreads. And by now we know that normal speech, just a little bit of speech, not the way I'm talking a little louder and so long, spreads the disease in the form of airborne particles, and it stays around for a long, long time. This is a very nice paper that was done by the NIH and the most, basically, I would say, knowledgeable people on the field. And it was published in the Proceedings of the National Academy of Sciences, which is not noted for publishing anything trivial. And as you can see, this is the curve with droplets, but look at the green curve, please. And this is the threshold that we need in order to have enough airborne pieces floating around that we could be infected with. And as you can see, it takes over 60 minutes for this curve to reach the threshold level. So if the person speaks for 25 seconds with a normal, soft voice with you in a closed space, if the person is shedding viruses, there can be aerosols of the virus floating around for an hour and 10, an hour and 20 minutes. So unless we are completely silent in the room, a simple surgical mask, not for the person who is shedding the virus, it does prevent the person from sprinkling it out. But for the person, if there are airborne pieces around, a simple surgical mask will not protect one from inhaling the airborne aerosol particles. Okay, I'm going to switch gears quickly to triage, and triage comes in two shades, if you will. One of them is triaging our COVID patients, which I will talk about second. But the other one that's important and is coming out now more and more, and here with Professor Gasparini, and up in Brescia with Dr. Betsy and her wonderful team, we are seeing this now, that all these patients who we didn't take care of during the COVID pandemic, and we should have actually, because it was difficult. But to die of a myocardial infarction or something else is no less important than dying of COVID. And so we have to create a triage schema that people who have other serious issues are not afraid to come to us and are not shunned by the healthcare system. And not in Italy, thank goodness, but in other places, I've heard of many, many physicians who practice in fields that are not typically elective and trivial. Their cases can easily be critical, with high morbidity and fatal, and with high mortality. Physicians in those fields who refused to accept calls, or only were willing to talk to a patient on the phone because they said it's too dangerous to see patients. And these patients, some of them unfortunately came to harm. This is a nice little short thing about in the New England Journal about the incidence of acute myocardial infarction. And this is in the San Francisco Bay Area. As you can see, the 2019 curve for acute MIs is the cream beige colored curve. The dark maroon curve is the red one. And as you can see, from the time the disease hits this area, the curves separate, and it completely coincides with the time that the COVID pandemic took off. Please note that this is not chest pain or angina. This is acute MIs. This is ST elevation proved MIs. So obviously you can say that people who were having mild chest pains and were otherwise just be called anxiety or muscle strain didn't come to the ER, but and that may have been fine. But these are people who actually had MIs. These are people who had myocardial necrosis. So I'm sure, sadly, some of these patients were lost. And this should be upon us as healthcare workers. This is not my field of expertise, so I will just be quiet about that part. But there should be schemas and patterns written by people who manage patient flow and epidemiologists. And we need to make sure that the message we give to our patients is not that unless you have COVID, stay home for now. We should say, don't stay at home. We are ready for you. We really are, because a sick patient who needs my care, your care, our care, is a sick patient who needs our care, whether they have COVID or not. Another aspect of triage is to validate scores and schemas to appropriately direction our patients to outpatient, to mild inpatient, to step down level inpatient, and to ICU inpatient. There's at least 4 levels of COVID disease. There's the very mild disease we send home. There's the moderate disease we admit to the hospital, but we don't expect to get much worse, and we hope to go home soon. There's the severe disease that we bring to a step down or NIV unit and watch very closely. They're the ones who more than others may decompensate and become critical. But again, we do what we can to reverse the process and not go there. And then there's the ones who come in critical condition in the first place, and they go straight to the ICU and mostly get intubated quickly. How do we distinguish these? There have been several of these produced, and I hope that with the data being available and people who are far smarter than me looking at it, more valid and better versions of these will be found and validated. This was developed and this was published in JAMA, I think about maybe 7-8 days ago, and it's based on several factors: X-ray abnormality, age, the presence of hemoptysis, dyspnea, any altered consciousness, number of prior comorbidities, history of cancer, the neutrophil to lymphocyte ratio, LDH, and I don't really understand why, but bilirubin was also included in this, and they give a probability score based on the total points to risk stratify. This is just one example. I'm not endorsing this one specific tool. I just had to put one here as an example. This is a very important part of our triage, because if we leave it to people to do it based on their clinical judgment subjectively, we all know from data on many other fields that people's subjective judgments are not reproducible by other colleagues. Yes, some of us are master clinicians, like my host here, and they may get it all right, but I'm sure I'm not one of those, and I'm going to get it wrong most of the time. So it's better to do it objectively and with measures that are reproducible. This is again to look at triage. This is a paper again that came out last night, this morning in the Blue Journal. It discusses 85 fatal cases, and for the 85 fatal cases, it lists. It's a very nice. I didn't put any data from it because it would be very long for this topic, but it lists some of the main important red flags that tell us the patient will do poorly, from imaging patterns to drop in lymphocytes. One of the important things that I saw in many of the patients, and these people talk about, are a depletion of eosinophils. I recommend that you flip through this paper very briefly and just look at the markers they find. And again, I'm not endorsing one or any of these specific schemas for prediction and prognostication. The only thing I'm saying is that this should be done objectively based on pre-approved and pre-validated hallmarks, not based on just looking at the patient and seeing our gut feeling. Our gut feeling helps, but it's always best if we augment it with objective numbers. Okay, I'm going to switch gears to pharmacotherapy. This is the part that some or many of you may disagree with me most, and I respect that sincerely and most honestly. We have our held beliefs strongly about things that we believe because we like to help our patients. But unfortunately, the COVID pandemic proved to many of us that our faith or belief in evidence-based medicine is not as deeply as we profess it. Many of the treatments that were used pharmacologically were not validated or proven to be effective, ended up being harmful, and were used indiscriminately and outside of clinical trials with a strong belief that they will work, of course. No one used them to hurt anyone. We did it to help people, but we didn't. And I'm just going to run through some basic examples. And again, if you disagree with me on this specific drug, I'm perfectly fine with that, and please do. And write me or call me and tell me why you disagree. I would love to hear from you. But that's not my point. My point is that if something does not have enough evidence, that we, with a strong heart, would give it to ourselves or our mother, being 100% sure that we're helping them and not hurting them, we shouldn't give it to any patients. This was a case series of tocilizumab, as you say in Italy, tocilizumab, to basically control sick patients induced cytokine release syndrome. And these patients had bad reactions to the drug and they died. And the paper discusses, this is the patient's imaging, one of the patient's imaging, and this paper discusses how, despite the fact that the IL-6 is somewhat increased in this disease, the quote unquote cytokine release storm, and it is there. When I say quote unquote, I'm not questioning its existence. I'm questioning its severity and gravity and how much it really contributes to the disease's severe morbidity and mortality. Whether that cytokine release syndrome, how it compares with other inflammatory illnesses like SARS, the other SARS, the main SARS, and other inflammatory and pneumonitis that we know. And also, even if it does contribute, and we are blocking it, which is not a slam dunk proven fact at this point, even if that is the case, how safe is it to block the immune system relatively early in the disease process when the immune system is the only thing you have to get rid of the viremia? The cytokine release syndrome is, again, questioned in its importance and its gravity in contribution to the disease's manifestations. So I believe this is one of the most important topics that may need research in the coming months. This is another aspect of the immune modulation is, of course, giving corticosteroids. Those of you who have practiced critical care and pulmonary and ICU medicine for as long as I have, and perhaps longer, the older ones, we know that this conversation about corticosteroids has been going on forever. And there's, again, strong arguments on both sides. This was a very nice paper, and they showed that an early short course of steroids is effective. The 2 points I want to make is this should be given at a certain point when viremia is not the main problem. This should be given watching the patient's hypoxemia and stopping the pulses if we don't see a positive impact on the patient's AA gradient or FiO2 requirements. And this should be given as 3 pulses for 3 days only. This is not a longer course of steroids. Lopinavir, ritonavir, was a drug that was advocated severely everywhere. Kaletra, it was given in staggering amounts to patients, and I think that it may have contributed to terrible harm because of its complications, not because of its effect. And as you can see, the effect is essentially non-existent. And this is the viral load of patients 21 days after they received it. Some people have claimed the study is not accurate because this drug was not given early enough. I question that assertion, but that is a very long conversation, and I don't think we want to do that now. This is probably the drug that people have the strongest opinions about, hydroxychloroquine, and its older cousin, chloroquine. As you know, this paper came out about a week or so ago, and it showed that hydroxychloroquine looked at in a very large pooled sample of almost 100,000 patients 96 and something thousand, almost doubled or more the mortality of these patients. Again, I have seen this study being questioned for when the drug was given, at what dose it was given. I hear that there are still several randomized trials that have not been stopped. I do hope and pray that the results of those will come out and they will put this to rest. One other issue with this study is that even if it does show that we shouldn't give hydroxychloroquine to our sicker patients, because by that time it may really not work, there's another aspect of this drug that people have claimed that in the early phases or in the pre-symptomatic phase, or in people who have or may have an exposure as prophylaxis, whether it may be effective in those areas rather than in the ill patients. And again, all I can say is these need trials. My being very vehement and strongly worded and my neck veins bulging out to try to prove that that's the case or that's not the case doesn't really matter. We need to have numbers and we need to have studies. Remdesivir, which is an ongoing conversation, the preliminary report that was put out, again, people may have their own opinions about this, and it's all very fine and well and respected. I really don't think the data at this point supports the use of it outside of clinical trials. As you can see, the overall rate of diminishment, as you know, the study did not reach a mortality benefit at a significant level. The outcome for the overall cases is essentially identical. It is almost, the curves almost superimposed for patients who don't receive oxygen, for patients who require non-invasive ventilation. Remdesivir actually does a hair worse for patients who are on mechanical ventilation or ECMO. The only group it had a very small marginal benefit in was patients who are receiving oxygen but don't require any form of non-invasive support. Let me skip this part because I'm running behind on my slides. I'm going to come to the topic of oxygenation and mechanical ventilation. As you know, people have put out different ideas about how these patients should or should not be oxygenated, ventilated, invasively, non-invasively, high flow, when to intubate, when not to intubate. As you know, these two gentlemen, Drs. Gattiglione and Marini, have put out their schema and their type L and type H patient that everyone already knows about. I think there is some merit to what they say, but I don't think it is as dichotomous as these gentlemen claim it. I think it is more like a very gradual spectrum from light gray to dark gray rather than being black and white. And there's a whole lot of patients in the middle gray that is not light or dark. And I think looking at this physiologically is extremely important. This is how my take on it is, and I may be wrong. I do not claim to be a histopathologist or a pulmonary physiologist or someone who masters the pathophysiology of ARDS by a far, far stretch. But like all of you, I've been involved in this. I've read as much as I could to try to make sure that I'm not making silly mistakes for my patients. And this is my humble and amateurish take on this. I think that the disease is not a single phenotype, and it doesn't progress in the same in all people. I don't think it's two distinct phenotypes. I think that early in the disease, in some people, the progression to typical hyaline membrane ARDS is a little slower. In these patients, we may have more vascular issues, microthrombosis, etc., contributing to the oxygenation fact. In these patients, if we cause ventilator-induced lung injury, or if we do not protect the patients from inducing patient self-induced lung injury, we may have a worse outcome and make the disease severe. The disease may, in some patients, not many of them, reverse if it gets to respiratory failure. In that early phase, it may reverse and get better. or in most of them, it does progress to good old-fashioned hyaline membrane ARDS, and then we have ARDS. But I do believe that if we look at things and numbers in a logical way, and if we deliver our knowledge of mechanical ventilation that we learn in a way that goes well with the physiology we learned from Dr. West and our masters, I don't think we really need to even pay attention to these minutiae, because we are not supposed to give plateau pressures of over 30. We are not supposed to give volumes over a certain amount. Even if the patient is taking them, we should stop it. If we need to paralyze a patient because they are hyperventilating and giving themselves extra physiological, super physiological volumes, we need to do that. And even if we don't know about the subtypes, we need to do that. We need to be aware of transpulmonary pressures and their swings, and we need to prevent those from causing alveolar lung injury. If we're aware of these, if we deliver the PEEP that we need to based on a very good old-fashioned best PEEP study that we can do at bedside in 10-15 minutes, and we are aware of that for every single patient, regardless of H or L or any letter you would like to give to it, I don't think we need to categorize patients in this way. We may be aware that they're early or later in their disease, but as long as we don't break the rules of pulmonary physiology, I think we're fine. This is just some images from their paper, and I will be a little faster now. You can see the microthromboses. This is the schema they suggest. It is good, but I may have some quibbles to it, but again, sadly, not time to go into it. The issue of proning is very important, and I think it is really helpful to use proning in the patients who have profound and refractory hypoxemia. Many patients are now advocating for proning patients on non-invasive ventilation. I know of many people in many centers who have tried this and have not succeeded. I know of very good and smart and able colleagues who've tried. It is really not easy to keep a patient prone for 6 or 8 or more hours if they are awake. And by definition, if a patient is so sleepy that they cannot protect their airway, they're not supposed to be on a non-invasive ventilation. And again, the studies from the past and present show us that proning for 2 or 3 hours isn't really helpful. We need to do it for 6 hours or more. So although this is advocated and it really works physiologically, I don't at this point really know whether it will be any form of standard behavior, because it's really not easy to implement. Again, the same concept. I will go very fast in this section because I'm kind of at the end of my time here. I have about 10, 12 minutes left. The decision to intubate patients always is a clinical decision. Other than a patient who has cardiopulmonary arrest, which is basically the only absolute indication for intubation. That's the only absolute indication that I know. It's always a clinical decision. We should look at many different things. We should look at work of breathing. Work of breathing should not be equated to respiratory rate. You could have a respiratory rate of 30 or 32 and not have a lot of work of breathing. My understanding from my teachers of physiology has been that the best way to gauge it is touch and look at auxiliary respiratory muscles, tertiary respiratory muscles, the sternocleidomastoid in the neck, and touching it and looking at it is the best way to find out how someone's work of breathing is. Hypoxemia and its refractoriness to oxygen supplementation, which denotes very large volumes of intrapulmonary shunting, are another very strong pointer. How much the patient's respiration, the respiratory problems, in addition to hypoxemia, are causing hypercapnia and acidosis is also an added factor. This does not tend to be an issue with COVID, most of the time very, very unusual. and also other ancillary findings like patients who have become encephalopathic because of hypoxemia or CO2 narcosis. When we do put patients on mechanical ventilation, as I said before, we should always maintain a target plateau pressure of 30 or less. We should be aware of and very keenly trying to minimize transpulmonary pressures in swings. We should avoid volumes that are supraphysiological, and we should reduce PEEP to the lowest level possible to control hypoxemia without using toxic oxygen concentrations if possible. And also, we should not forget of the importance of PEEP in preventing high transpulmonary pressures and lung injury. This was a really wonderful paper that came out just 3 days ago from Norway, and they look at the correlates between aviation medicine and high altitude medicine and respiratory failure in COVID, and the fact that hypobaric oxygen does have very similar effects to the hypoxemia that we see in COVID because of microthromboses and poor perfusion of the effective capillary membrane, and how being attentive to the level of PCO2 and not trying to, I repeat, not trying to correct the hypocapnia, the hyperventilation in these patients is important because the hypocapnia and the alkalosis actually shifts your oxygen dissociation curve in the right direction and allows you to extract much more oxygen in the tissues, which is what matters, not in your blood gas. And as you can see, just increasing your PaCO2 from 2.5 to 4.5, which is normal and acceptable in you and I, would basically decrease their SiO2 from 87% to 50% and basically create severe tissue damage, lactic acidosis, and death. This is the editorial that goes with it. I really recommend reading these two papers. They're both very short, both the paper itself and the editorial, but they were extremely informative to me. I will skip the part about patient and self-induced lung injury because this is just too much detail, and unfortunately we don't have the time. This is what we are trying to avoid, these huge pressure swings, and this is the classic test. This shows how the patient self-induced lung injury and is more in the dependent part, and this is how elastance impedance tomography, which shows where most of the stretch is because of the increased volume, causes inflammation, hyperemia, and damage. And this is the classic curve that uses esophageal pressure that, as you all know better than I, is the best correlate and surrogate that is easy to measure for intrapleural pressure to show that when the PEEP is increased, the PEEP just goes up, so the airway pressure just raises a notch and goes from this to this. So the amplitude here doesn't really matter very much. The amplitude remains the same. And as long as this is not going over 30, we're okay. But when you do give some extra PEEP in these patients who are taking large breaths, you diminish the esophageal pressure swings, which, as you know, correlates with pleural pressure. So we are avoiding this, and hence we are avoiding this. This is the damage. This is just one not very beautiful image that depicts this. This is these are patients who are given high PEEP versus low PEEP, high PEEP versus low PEEP, and these are spontaneous breathers. These are non-spontaneous breathers, and you can see in both instances the ones that were given low PEEP do much more damage to themselves. The topic of anticoagulation is very important. As this disease became more known to us, we became more familiar with it. We learned that this is a disease of thrombotic consequences, both macro and micro thrombi. As the original French study, that I think the first one that came out in a large number, showed patients who had been in the ICU for just several days, 20, 30, or 5% of them had pulmonary emboli. And we know this is a disease that it messes up your coagulation system and it creates a hypercoagulative state. And this, again, is a very nice series of pathologies, and it shows the thrombotic consequences, but it also points out to the fact that in these patients, in every single one of them, of the 10 patients, they all had hyaline membrane disease. Unfortunately, my marker isn't my my pointer isn't working, but the tall histopath image in the middle of the image down there shows the thick hyaline membrane, and the one next to it shows the classic multinucleated giant cells. So you could see there that this is our good old-fashioned ARDS, and it was seen in 10 out of 10 of these patients who died. This shows the vascular consequences of the disease. I lost my pointer, Dr. Gasparini. I lost my pointer. It's okay. I'm sorry, I lost my pointer. So you have to kind of like, I'm going to point in the air and you have to imagine you see where I'm pointing to. This is a patient who has a relatively small COVID infiltrate. And as you can see, those arrows that are pointing to those little round white spots, there is thrombosis and obstruction in the blood vessels leading to the area. This is a dual energy CT scan, and the yellow halo, the darkness of the yellowness, if you will, points to more or less hyperemia. And as you can see in both areas, both the larger one on the right and the smaller one on the left, you see a nice yellow halo around the involved area. And so one of the issues with COVID is that it disrupts and messes up our normal pulmonary vasoactive responses, and we get hyperemia instead of closure of the blood vessels to areas that are not being ventilated. So one of the mechanisms, one of the perhaps main mechanisms that the disease causes very severe refractory hypoxemia in patients is by creating very large areas of intrapulmonary shunting. To be aware of this points out to the importance of anticoagulation in this disease. This again is the comparison. The large arrows, the thick green arrows, are pointing to the area of the halo. And these are basically some images of those clotted blood vessels, the small and the large, the bigger and the smaller arrow. These are again organized thrombi in patients who did not have macroscopic thrombi on CT. This is a very nice study that showed that as the patient stays in the ICU longer and longer, the percentage of patients who have arterial thrombotic events increases. So as you can see, every day a patient stays in the ICU more, their need for anticoagulation is more and more and more. So it's better if it started as soon as possible. It was after these studies came out that the American College of Cardiology, and with a very short gap, the European College, both put out guidelines to use anticoagulation. These two studies show that very nicely, as you can, the one study, sorry, these two graphs I meant to say. The red graphs are the patients did not receive anticoagulation. The blue ones are the ones that did receive it. And the graph A is all of the patients, and B is the ones that were sicker and required mechanical ventilation. And as you can see, there is significant parting of the curves. They're very wide apart, and there is very, very decent sized p-values. And so anticoagulation definitely saves lives. I will have to skip this. This is a wonderful paper on, it goes through all the mechanisms, and it's not like super biological, so someone of my level of understanding, and I'm not a biology or a bench scientist understands it. So if you like to really understand why the anticoagulation goes so berserk, this is a very wonderful short paper to look at, but I will skip it for now. These are some of the mechanisms listed here. And this shows the vascular damage. Unfortunately, my pointer isn't working. This shows the vascular damage seen in an autopsied lung. This shows the thrombi. This shows that the casts, even in the micro vessels, you can see the tiny little vessels, the arrowheads. These show that the smallest level of capillaries in the alveolar wall. They're crammed with these thrombosed RBC casts. This is a really nice image because it shows plate A is a normal alveolar capillary network with the alveolus, the alveolar cells having been stripped away. Plate B shows the same exact capillary in a COVID patient. And as you can see, it's moth-eaten. It's like a little moth nibbled all over it and made little holes in it. And when you look at it in higher resolution in plate C down there, you see that there is intussusceptive neovascularization, which is a dysfunctional form of vascularization that the vessels split in the middle. And I can't explain it now in detail because of time, but it shouldn't be happening. And the very, very interesting point is that it doesn't seem to be immune mediated, as some people have hypothesized. It seems to be directly cytopathic because the vessels, the endothelial cells in those vessels in plate D down there show tons of COVID viruses right inside them. The RCs are red blood cells, and the capillary endothelial cells are packed with COVID viruses. So much more likely than not, this is probably cytopathic cell injury rather than immune-mediated disease, as we may have gathered. And this shows how this intussusceptive angiogenesis over time gets worse as the days of hospitalization go forward. On the X scale, you have the days of hospitalization, and the red curve just sharply going up is how badly you see this. And as you can see, by day 10, it's almost up to 100, which is the maximum score they had. This was the European Council, the European Society of Cardiology's guidelines. These were perhaps the nicest and cleanest ones we had. And so I'm almost sure that all of you have seen this and are using it in your units or some modified version of it. I think anticoagulation in all COVID patients to some degree, and unless a patient has a very strong reason to not have anticoagulation, making an error, being more drastic on a little more anticoagulation than a little less will probably save more lives than hurt people. This was a very nice case study in the New England series, and it showed that this is why our chronic renal replacement therapy, our chronic dialysis filters kept clogging up every day because of the coagulative predisposition of blood in COVID patients. We would get clots, and sometimes in one shift you would have 5 or 6 filters thrown out. And how adding replacement fluid, and especially replacement fluid with citrate, because it chelates the calcium, it diminishes the likelihood of blood clotting. Again, there's too much detail to be said here, so I have to skip it. This is from my kind, good, and wonderful friend, Dr. Gianpietro Marchetti in Brescia. This sign is on his wall, and it reminds me of lessons that my old teachers gave me many times when I was much younger and in my learning years. We should all always learn to think about everything. It is never too much thinking. You're never too late to think. And you can't say, oh, I'm too old to think now. We need to keep thinking. And these are some of the editorials that I really recommend people take a look at. Not because we or you don't think. I'm sure all of you think much more than I ever did. But these are nice guidelines or nice pointers to our younger people that thinking and not taking words for granted and not going with the flow and being inquisitive and curious are very, very important parts of taking care of complicated patients. I quoted Bill Gates, so I will quote his opposite. Someone about 170 years ago said, history repeats itself, first is tragedy, then is farce. If we do not learn the lessons of what we did with COVID and do things we did right better and do things we did wrong differently, people will laugh at us later, sad tears. I love this line. I learned it when I was a teenager from Bertrand Russell, that just because other people say something, it doesn't mean that it is true at all. I will just read off of it because I can never say it as nicely. The fact that an opinion has been widely held is no evidence whatsoever that it is not utterly absurd. Indeed, in view of the silliness of the majority of mankind, a widely spread belief is more likely to be foolish than sensible. I just want to take a minute to thank all of you, my Italian friends, my Italian colleagues, and everyone in Italy for accepting me here, being kind to me in this period, and taking me as one of your own. I cannot tell you how many times a day I would become tearful from people, random people on the street, in the hallways, corridors of the hospital, coming up to me and thanking me for things I hadn't done. And how many people brought me food? How many people wondered how this weird foreigner is surviving for several months in a country under full lockdown? I have had the best meals, some of the best meals in my life brought to me these past few days by people who didn't know my name. I kid you not. And I think you as a country acted like heroes. You came together and you did it, and you did it well, and you became an example to all of us. I want to take a second to thank my friends in Brescia, in the Civili hospital there, everyone there, every single person, my gracious and kind host, Dr. Michela Bezzi, my wonderful friends, Federico and Mauro and Daniele and all the other wonderful physicians I worked with there. I want to thank Dr. Gasparini, who has always been a wonderful friend, an older brother, a teacher, a mentor, and more than anything to all of us in this field, in IP, an inspiration. And I cannot thank him enough for who he is and what he does for us. Italia, sei una nazione di eroi, è un'ispirazione. A tutte voi, grazie mille, grazie un milione, grazie.
Well, I'm Stefano Gasparini, and I take the word now. Thank you very much, Mohsen, for your kind words at the end of your wonderful and complete presentation. You evaluated all the critical point of this COVID time, from diagnosis to treatment to ventilation, and everything. You showed us a lot of very interesting literature and what the evidence is. Well, thank you very much. Thank you for coming in Italy. Thank you for being available to take this webinar for Italian Association of Pulmonary of Hospital Pulmonologists in the Italian Thoracic Society. Well, probably we could have a few minutes for some question. I receive a question for Mohsen from the colleague Simona Bennati that would like to ask to Mohsen, what would you use to study the asymptomatic patient or to identify the asymptomatic patient? This is one question.
Thank you to my wonderful colleague for asking this intelligent question. The only points I have to say is, by definition, you can't study asymptomatic patients. The two main steps that we need to take to diminish the harm to our healthcare system, our patients and society at large, and our healthcare providers, is that one, we should put in place everywhere better places for contact tracing. Contact tracing is the most important way that we isolate people who may have become asymptomatic carriers, and then we can later serologically prove that or rule it out. And number two is that as soon as there are signs of diseases with high contagion like this, we should be vigilant, come together as a society, and observe very basic means of protection. I don't think we need to shut down our countries. I don't need to, we need to shut down everything. Caution and common sense, and what we are doing right now, even less than what we're doing right now, if we do it right, make sure we don't touch things too much, clean your hands whenever you do, put those masks on all the time, don't be in non-ventilated rooms without masks. These are how we protect against asymptomatic carriers who may make other people sick.
Well, if we have no other question, I would have asked to Mohsen, from the data that you showed us, it seems to me that the only treatment, the only drug that showed some evidence, for which we have evidence of benefit, is anticoagulant, is heparin.
Yes, but drug, if we're talking a drug as in a pharmacotherapy, I agree with you. I think the only thing that we have seen, and I personally believe, if my humble opinion matters, is really something we could deliver, administer to patients as a medication that really has a higher likelihood of changing their outcome. It is indeed anticoagulation. But I think good critical care, being at the patient's bedside many, many times a day, looking at the ventilator curves, adjusting the pressures, the volumes the way we should, and fine-tuning ventilation. It may not be a drug, but it saves more lives, just as much lives or more lives than any drug.
Well, thank you very much. We have no more questions, so I thank again Mohsen for this wonderful presentation and for his availability to be here and to help Italian people. And I thank IPO ITS for organizing this interesting webinar, and for all the webinar that our association organized during the COVID disease. The collection of IPO webinar is a great result for all of us, and I'm sure that every pulmonologist in Italy will benefit for this great concentration of information that have been done by IPO webinar. Okay, and now I would like to say goodbye and thank everybody, and Mohsen also.
Goodbye to all of you. Thank you very much for everything. I always knew Italians had the best food and the best fast cars. Now I know they have some of the best doctors and nicest people in the world. Thank you.
Thank you, everybody, and goodbye.
Thank you.